This is It's Not In Your Head podcast with Dan and Jez. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hey guys, welcome to another episode of It's Not In Your Head. I'm your co-host Justine Feidelson, here with Dr. Dan Bates. Hey Dan.
Morning, how are you?
Good. We've gone through a lot of the different algorithms thus far with regards to what does nociceptive pain look like, what does neuropathic pain look like, what does sensitization look like, and how does it present. But today we want to give you a couple more tools, piggybacking off the last neuropathic pain algorithm episode that we did, where Dan talked about some different ways that as a patient, you can measure, how you are presenting and how severely you're presenting in some of the different types of pain that we talked about prior. So these tests are already validated, they exist, they're out there, they're used commonly by practitioners, and they're things that you as a patient can, after this episode as well, go onto our website, check them out, and download yourself so that you can start to better assess and understand how you are presenting as far as neuropathic pain and what aspects and elements of sensitization, as we've teased apart before, are possibly adding on to that. So this episode is about giving you a set of tools that are easily accessible and really a starting point to work from so that you can see what is your baseline, functionally, what is your baseline emotionally, and how do those things tie into goal setting from the perspective of this is where I'm at right now, and how can I compare my progress down the line as I start to better tease out and tease apart what are the different aspects of my presentation. Because when patients go in and they say, I'm an 8 out of 10, right? That 8, it's not just the type of pain. It's the pain plus the amplifiers, plus the loss, plus the catastrophization, plus a lot of these, additional functional challenges that accrue. And so if you as a patient can better see what are the different parts that are adding up to your 8, and most importantly, what type of pain to begin with is mostly contributing, you then have a much better understanding of why are you in the position you're in and how can you start to pull apart that tangled ball of yarn. So that's our goal for today.
Nice. And look, we've talked about this before as well, that pain is so complicated that it's hard for anybody else to actually get an idea of your pain. And so these are a set of tools that you can do to sort of start to tease your pain apart and to understand each component that you're experiencing. And then once you understand each component you're experiencing, then you can start to better target what therapies are going to be best for you to start off with. So There we go.
Yeah. So we'll go through a number of main ones today. We'll cover first the central sensitization inventory. We'll also get into the DAS-21. We'll then cover what is called the pain detect. Besides that, we'll also go through the Oswestry disability index, which is the functional measure. So that's not looking at the type of pain that you're having. It's more looking at how much is it affecting your activities of daily living, right? Your sort of everyday quality of life stuff. And then given all of that, we will introduce a questionnaire that really helps you look at from a sensitization perspective and bringing into the conversation the way that Dan and I have teased out sensitization and the different buckets that we look at it and have introduced in the algorithm as far as how does it present, and being able to better match the symptoms that you're having, the other diagnoses that you're having into, yes, I have central sensitization, but what does that look like and how is it primarily affecting me as far as mood, motor, cognitive, etc. So it will give a little bit more nuance and context to the way that central sensitization is currently assessed and look at it a little bit through the lens that we've developed so that it's a bit more individualized to your specific situation.
Perfect. What I'd like to do to kick in first is actually like to talk about the pain detect first, because it basically works with the way when I'm seeing a patient, this is what I'm doing first. So the pain detect was first developed in 2006. The idea of this measure was so that people could go and fill it out themselves, and then you can then rate whether you have essentially body part pain, also called nociceptive pain, or you've got neuropathic pain, or whether you've kind of got a mix in between, or it's a little bit unclear. And so it's not very good in people who've got fibromyalgia because you get this very big mix of pain signals. But within a number of other settings, it's actually really quite good.
And that's a great point too, where then for something like fibro, you would want a different test to assess it. You would want to use something that's more geared towards widespread sensitization than one of these more specific ones.
And we'll look for a fibro type questionnaire.
Assessment.
I don't use them, I just ask. And I think the thing here, particularly with pain detect, I actually don't use the pain detect because when I get somebody to come in and see me, I am asking those questions. I'm trying to
Right.
work out, have you got body part pains? Is it nociceptive? Is it 8, sharp, dull, pressure?
Right.
Is it focal? Is it, blah, blah, blah. And I'm trying to work out whether you've got neuropathic pains. I'm just going to ask, have you got
Right.
burning, pins and needles, numbness, itching, crawling, painful, cold, painful, squeezing, etc. That is effectively what the pain detect does.
Right. Because Dan, with experience, can ask this and pull this out, but not necessarily others. And then this way, you as a patient have that to take in rather than relying on however you're being assessed.
Yeah. And so when you look at the pain detect, you can have a look at it, you can fill it out. So when you score it, it gets scored in between 0 and 30. And so for scores of 12 or below, it's most likely body part pain. But it's more defined as it's 15% or less chance that it's neuropathic pain. And so then you've got 13 to 18, at which it's a mixed picture. It's unclear whether it's
Right.
just
It's not purely neuropathic.
nociceptive or it's
right.
Neuropathic. And so it's probably a bit of mix of both. And then above, like 19 and above, it's a 90% chance that there's a neuropathic component
Element.
So that doesn't mean that it's just neuropathic pain. It just means there's probably a neuropathic element to that.
Right. Much more likely it's present.
Absolutely. And so that automatically for you starts giving you ideas around, well, you should be thinking about, I need to be on some anti-neuropathic medications. We need to be thinking about causes of neuropathic pain, blah, blah, blah. And so that then gives you that automatic guide and gives you something you can talk to your doctors about. So after that, the next thing that I use, and I use this a lot, is then the central sensitization inventory. So central sensitization inventory, I think, was developed in Austin in 2012. And what they did is, and I think we'll have to sit down and talk to them sometime because, back in 2012, they'd obviously been thinking about it for a long time by the time that they'd been able to think about it, do the study, publish
Organize
it.
Publish
That's
it.
5 years of work by the time you get to that. And what it does is it actually goes through and it breaks down central sensitization into all its components and asks you a bunch of questions. There's 2 components to it. The first part is 25 questions that asks you, have you got this symptom or that symptom? And it gets you to rate it from never through rarely, sometimes, often, and always. And each one of those gets a score. So never is 0, rarely is 1, 2 is sometimes, 3 is often, and then 4 is always. And you then go through and add up your score, and you can then work out how sensitized you are. And so what that does for me is that allows me to get a bit of a sense of what's happening in the background and and how amplified is this pain. And so that becomes really useful. So once again, this questionnaire, it's categorized. So below 30 is, I think it's 29 and below, is subclinical sensitization. And so
not as impactful and not as intrusive. You might have some elements, but it's not.
And so then the next piece is then from 30 to 39, which is mild, and then 40 to 49, it's which you then get labeled as essentially sensitized. So like you only get the label over 40. 50 to 59 is severe, and then extreme is over 60
plus.
And the highest score I've ever had a patient hit is 85, and they're in all sorts. So getting like someone ticking 100, then there's something else going on. So it gives you a bit. And so how I use that when I see somebody is that if you've got a score under 30, the likelihood that this is neuropathic or that you're centrally sensitized, like this is a nociceptive problem. I'm like, awesome, bring that on.
Yeah,
I can go find that. Yeah, it's body part. I can go find that. And then, you get them to draw their pain. So they're not sensitized. They've got focal pain.
Very local.
Like everyone's passing high fives
home
around
run.
the room.
Next.
Just go find what that is. In many ways, like that is sort of the way when it's below 40, kind of the same. Once you're into 40s, there's a component of sensitization, but I don't think it really impacts enormously for me on how I manage the patient in that setting. I still are going to be, that is more likely to get into this mixed nociceptive neuropathic type environment, but it doesn't really.
It's not screaming sensitization being the
Yeah.
primary party responsible for how out of control the situation has become.
Yeah, where this changes my decision making is above 50 and then above 60, where I do two slightly different things. If you're above 60, the likelihood that when I do a diagnostic block,
no
you get
procedures.
worse because of the needle, not because of what we inject, not because of where we inject it.
It's not the technique.
It's not the technique. It's just the pointy thing.
I've been there. Yes.
Just been there. The likelihood that you're going to blow up in a big ball of pain is really quite high. And so for those patients, I shift from trying to find what's driving the pain, what is the nociceptive or neuropathic driver, to trying to turn down the sensitization.
Treating the sensitization. So when it's super high, that's what you prioritize first if you can.
Yeah, exactly. So turn the sensitization down.
Yeah.
And that's really where I go first.
And we've talked about that a lot too in past episodes, where if you can help it, try not to do procedures on highly sensitized patients. And this is the tool that can allow the physician to better navigate that point. Yeah.
And so that's it. And that's my number, 60 and above, and no injections. And unfortunately, I had to learn that the hard way, or my patients had to learn that the hard way. And so that when I was like, look what happens when they're over 60, that's no good. We should stop doing that, Dan. And I did stop doing that.
It's the darndest thing.
Anyway, so then between 50 to 60, it varies. I basically make a judgment call in that setting. And interestingly, it might be that it is the nociceptive or the neuropathic driver that is driving the majority of the sensitization.
Yeah.
And so that's when I start to tease apart what features of sensitization have you got. And we'll talk about that in just a tick and how you do that. Right. And so that's really the judgment call. The judgment call is, well, actually, no, the problem here is the problem. Just
get the problem.
Find it down and treat it.
Yeah.
Yeah. Versus,
problem's really small.
Yeah, the problem's really small and it's amplified to hell.
Right.
Then go treat the amplifiers.
Don't keep looking for the problem through all that. Yeah.
Exactly. So that's kind of how I use that tool. The second part of the central sensitization inventory is called Part B. Part B's got about 10 different bits to it. And so basically what it is it's a questionnaire about what central sensitization diagnoses have you got.
Right.
So
specific
have you
diseases.
got chronic fatigue syndrome, restless legs, anxiety, depression, neck pain, multiple chemical sensitivities, yes, and fibromyalgia. So if you've got, they basically go through, have you had these? Yes, no, yes, no, yes, no. And so
you get a bunch of symptoms that it asks about and then some specific diagnoses.
So it gives you a score and that gives you the specific symptoms. And so Part B doesn't actually add to Part A, but it just
adds questions.
Tells you that.
Well, Part B is kind of what it's in part inspired how then we further dug into and pulled apart what exactly is central sensitization and what are those types of diseases that then get diagnosed as other things, but they're fueled by this process. So there's massive overlap because they're in some cases the same, in some cases different. Yeah.
Sure. Okay, and so from there, what we can step in to talk about is just, there's another thing that's been developed over in the Netherlands called the Bodily Distress Checklist. And so it's once again a 25-point checklist that allows people to go through and identify essentially different components of central sensitization. Now, they don't label it as central sensitization, and there's, from what I can find, there's no references that link bodily distress syndrome with central sensitization, but it seems to be exactly the same symptom.
Very
from what I see, it's the same stuff. So,
and check out, reference the History of Hysteria episode if you're interested in a little bit more on this specific test, because we talk about it in that context too. Before those terms like central sensitization were used, this is what was dominant.
And so bodily distress syndrome checklist, it's really well developed. It's really well validated. It's just that I don't really like it because it doesn't give me enough information. And so I think if I'm going to get people to answer a bunch of questions,
it needs to give you what you want out of it.
Needs to give me what I want and what will be useful to patients. So along those lines, we've got our own little checklist, which isn't that little actually. But basically what
No,
it
it's quite
does
hefty.
is, yeah, it is quite hefty, but it's completely unvalidated, but it's basically what I ask in a history. So if I was to see
Right.
you, a bunch of these questions, I would just ask all these questions to define, the central sensitization inventory tells me how sensitized somebody is, and
But
then
not,
these,
yeah,
but not where they
how.
are sensitized.
Yeah.
No, they
Tells
tell
you
me how
how
bad they
sensitized,
are,
but not,
but
yeah.
not how they are sensitized. And so
Yep.
what it is, you can sort of look at it there on the website if you like. And basically what it is it just goes through those 7 buckets. So do you have sensory hypersensitivity? So you've got widespread pain, you've got focal regional pain, you've got like sensitivity to light, sound, touch, taste, etc., etc. Do you have sleep disturbance? Do you have cognitive dysfunction? Do you
Yeah.
have dysautonomias? And so it just goes through each one of those. And really, what the intent of this is if you're trying to tease apart what's going on for you, you can just work through, tick the buckets,
Right.
tick the boxes, and you can go, well, I've got none of that, and I've got none of that, but geez, I've got a ton of
A lot of that.
gastrointestinal.
Right.
And that might be, maybe it's just all my tummy that's driving all this
Right.
sensitization. And since I've started doing this with patients where I'll sit and I'll just go through, you're sensitized, and I break it down, that is
Right.
exactly
'Cause
what I'm starting to find. You'll go through and I'll be going, well, you've got none of that, and you've got none of that, and you've got a ton of urinary symptoms. Wow.
Right.
Okay. This looks like it's all being driven by urinary dysfunction. Let's get that sorted out and see what else calms down. And so I found that process really useful. You've got something to say, I can tell. Go.
I forgot it now. That's why I get interrupted. Just so everyone knows, that's why I get interrupted, because I'm afraid I'm going to forget what I'm going to say, not because I actually want to interrupt Dan.
And the brain fog's not too bad today.
No, I know. I can't even blame that. But for me, right, this is what I'm looking at over and over and over again, is the sensitization piece in patients typically, because everyone's got very high sensitization levels. I should say not everyone, often though, with CRPS and other things that are not
everybody
addressed long term, right? Everyone I see, unfortunately. And so this is the process I'm going through with them, is asking them these same questions, pulling out the same dominant buckets. And that's something that, frankly, you as a patient should and can actually do. Prioritizing things, treating things, progressing things, right? The strategies and the education to actually change things. Yeah, that's a different conversation. But this is where you can start to get a clear picture of what, like Dan said, are your primary drivers. Because what I often see is it's not that people present with a little bit of all the buckets. It's that they present with dominant 2, 3, 4, whatever it may be, buckets, and then very little of some of the others. So if you're one of those outliers who's got a little bit of everything, it may be a little bit less helpful. But what I tend to see is that it does jump off the page, because that's my job to then pick out, all right, how are we attacking this first, second, third, right? What's most impactful for you? What's causing the most amount of issues? Tackle that first. It's pretty straightforward.
And for those patients that do have a bit of everything, and I've got a bunch of patients that got a bit of everything within the autism spectrum disorder literature, but basically what they did is they looked at a link between ASD and central sensitization, and they did what's called a systems analysis or something along those lines, or a cluster analysis. And what they looked at is which symptoms drove the other symptoms. And so within the autism data, it was found that photophobia, which is hypersensitivity to light, and anxiety were the 2 primary symptoms that went on and drove other symptoms of central sensitization.
Right.
So if you go through the checklist and you tick all the boxes and you go, where do I start? Okay, the answer is you start at treating the light sensitivity, which quickly is FL41 tinted glasses. Boom. And
low-hanging fruit, put glasses
easy.
on.
And then you get on top of and you deal with the anxiety. And so they're the 2, that's where you start.
Yeah. And actually, I think I should amend how I said it. What a lot of the other buckets come from is not necessarily the pain presentation or the driver, but some of these coexisting other things that then add to. And yes, a lot of people will present with stuff in every bucket. There's just some more dominant buckets typically, but absolutely, especially when you take that into account.
Yeah, and it allows you to prioritize what you're going to do and where you're going to put your cash, because let's be honest, everyone's putting cash into this, so make it
as efficient as possible. Yeah. All right.
So Next questionnaire. DAS-21 is the Depression, Anxiety, and Stress Scale, and it is
Emotional component.
And supposedly it's 21 questions. Originally it was 42.
Was it called the DAS 42 then?
No, it's called the DAS. Then it was called
Oh.
the DAS 21.
Oh, okay.
This is a scale that was actually developed in New South Wales and Australia. And so I think it's probably something that, because everyone gets biased towards their own stuff,
Homegrown.
We probably use it more often in Australia than elsewhere. I really like it because it gives you a breakdown of what's happening for the patient. You obviously get a breakdown of how depressed they are,
right,
how anxious they are, and then how stressed they are.
Yeah, it's a big piece of the puzzle.
It also then will break down the degree of which that is taking place. So it'll be like normal, mild, moderate, severe, extreme, and extremely severe. So it's got a relatively broad way you can define your level of each one.
Right.
As a clinician, what I find, and this is becoming increasingly apparent for me, is that time is such a massive limiter to me being able to deliver care, because across the board, and that's an interesting discussion. But so when somebody's coming in to see me, they're coming to see me with something that's highly complex, and I've got to work my way through it. But I've got not only do I have to work my way through it, I have to explain it. I then have to be able to write a letter to communicate it to everybody else. And so time is a massive limiter. So what the DAS-21 does for me is it gives me a number that gives me this depressed, anxious, or stressed.
Right.
And I can just go straight to it. We don't have to spend time going, hey, how do you feel?
A bunch of,
a bit flat. And which people don't want to tell me at any rate.
Right.
I can just go, wow, based on the scale, you're really depressed. And patients and everybody goes, yeah, I really am. And we're just straight to it. It is honest. A very efficient use of the clinical time.
Because you're not taking away in the clinical time doing this when someone can walk in the door. Also, same with a CSI, right? It's much better for you if boom, CSI score, rather than verbally talking through it with the patient. And then you can
how do I work it out, how sensitized you are. So, so I find that's and you know what? I started using it as a cheat to be able to move things through, and for me to be able to identify how much of this is an emotional component that I then need to be able to move on with. And the stress part is really interesting as well, because it's very hard to step into people's stresses and what's happening for them in life, and they can't. And stress, it waxes and wanes, And so having somebody who comes in with a really high stress score allows you to be able to go, okay, there's other stuff going on in life at the moment. How are you managing it? I don't have to step into that problem. I don't have to fix the problem. I shouldn't fix the problem. It's not for me to fix.
Right.
But we can go, okay, what are we doing to manage your stress? What strategies you've got in place? Okay, we don't have any, no problems. Right. I'm going to tie you in with somebody who's going to help you build those coping strategies. And that's how I use the DAS-21. And it's really, really useful. I like it.
Yeah. Well, yes, this pulls out the emotional piece of amplification. So how much is mood, basically. And it's difficult not to have some element of this, and it's just how intrusive is it.
And I think you've got to realize that if you are not in some way depressed, anxious, and stressed, and you've had chronic pain for however long or however short, and it's taken away whatever components of your life, if you're not depressed, anxious, and stressed about it, you're not normal. So it'll be at
by
some
default.
level.
Yeah, people have 5 of the 7 buckets because sleep, fatigue, mood, brain fog, boom. There you go. So it's easy to accrue.
It's okay. We just need to identify it and then treat it. So
and it's not different for conservative stuff versus the interventive things. Dan too is pulling out. Well, if the primary driver is stress, not something he can stab and jab, he's going, hey, let's deal with the stress, and then we can get to that. Even though the patient expectation is often stab and jab me, but that's what you need, is to highlight, pull out, and then do things in the right order. All right.
Yes. So the last one we'll sort of highlight is the Oswestry Disability Index.
Yes.
Oswestry Disability Index was designed basically to define how functional or somebody was, or their level of disability. Yep. And you can use it as a means by which you can track people over time.
Right.
there's lots of research around with the use of the Oswestry Disability Index to show how people get better from a functional status. Like you
Right.
use it to set goals, don't you?
So to compare, right? Once either, yes, initially you can go, what out of those things, for example, if you're not looking at it in front of you, what it would cover is pain intensity, personal care, lifting, walking, sitting, standing, sleeping, sex if applicable, social, travel, right? So you can look at those things and go, geez, what of those have I lost? What would I want to get back? What do I want to work towards? Assess where you're at and then compare as you move, through time. And I'm using this exact thing even, for my own goals at present. So I could pull out sitting, standing, and some of the other things from there that I know exactly where I'm at right now and where I want to measure my success at certain points. Is my rehab working? Are the things I'm doing affecting the things that I want them to? And so sometimes also pain can not get better, but function can improve. Sometimes that's helpful to see that as well, where pain intensity might stay similar, but oh, wow, I am able to do more and I am more functional, which then would point to better coping or better stress strategies or some of the other things around it that have maybe come along to create more capacity. And now you're not overflowing, so ready to just flare from anything that you add in. So it gives you a really good sense of not just how do I feel, but how am I existing in my daily life? How am I navigating chores and challenges? And which ones do I want to impact?
And I think this for me at the moment, I'm using particularly the central sensitization inventory and the DAS-21 a little bit to sort of track how people are responding
In the same
to
way. Yeah.
therapies. Because so for one thing that we're doing for a number of patients is we're doing stellate ganglion blocks for people who are highly sensitized and have a background of PTSD or significant anxiety. And
Yeah.
so what I'm aiming to do there is turn down the sympathetic component of their sensitization and see if that will
Right.
help improve them. Now, from a verbal perspective, if you ask somebody, how do you feel? What
Yeah.
everyone says is, I'm better. I can't tell you how I'm better, but I'm
Right.
better.
It's too
Like
vague.
I saw whoever the other day and they normally really upset me and I didn't get upset.
Right.
Like that's an improvement for me that wouldn't normally take place. And so what that generally, interestingly, that commonly from what I'm seeing will correspond to like a 10-point or more decrease in somebody's central sensitization inventory. So they'll go from
Yeah.
mid 60s to mid 50s and that just corresponds to I just feel better. I'm like, okay, well that now I'm starting to see a number, which then means that, if that's we can then go, okay, our number's tracking back up. Can we repeat it? Bring the number back down again while we're working
Right.
on other things on the side. So those, that element of tracking, although even though, CSI is not designed to do that, that's how I'm using it at the
Right.
moment.
But yeah, and it's the same questions are in there that me too when I'm sitting down with clients, right? You're assessing them and then you are having conversations over time going, this is where we were, this is where we're at now, this is what it still needs to be improved, this is what's gotten a lot better. And that's a huge piece of feeling like you're making progress and helping yourself be aware of that. Because it's really hard with we could do a whole episode on this too of just the pain scale, because that number represents so much. It represents so many things rather than just the pain or just how you feel. So if you're not tracking anything other than a number, you can't tell either in a lot of
Yeah.
meaningful ways.
What we're referring to there is that if you look at a pain scale, pain 0 out of 10 versus 10 out of 10
Right.
better than worst you can imagine, right? So basically, one of my friends, Professor Dr. Ridar, did a study. They published it in 2022, and what they did is a cluster analysis where they looked at a visual analog scale, they looked at pain catastrophizing, they looked at pain vigilance, and they
Right.
looked at quality of life, and they looked at Oswestry index.
Numbers for that.
And then what they did is they brought it all together in what's called a cluster analysis, which is kind of cool. And they looked at, well, what does a 5 mean? What does a 6 mean? What does a 7 mean? What does an
Yeah.
8 mean?
Right.
Relative to these other questionnaires, effectively. And so basically what they were able to show is that less than like 5 and less out of 10 people have minimal suffering. And so in that setting was more around And they were using suffering, particularly out of focusing on the pain catastrophizing scale. And so between 6 and 7, people have increased suffering. So that's when they're starting to describe words using, more emphasis, this is terrible, this is blah, blah. So you're starting to use those catastrophizing set of words. And then 7 and above, you started to have increased disability. So that's where you get a drop off in your Oswestry disability index.
So you're still there plus disability.
So now you've got suffering plus disability. And that's how it sort of comes together. And so when a doctor asks, like a doctor, i.e. me, I ask 3 questions, right? When I'm trying to get a pain scale. So what I'll say is, what's your pain out of 10 at its worst? And how often is it out of 10? And so what I'm trying to look at there is, how often is it really bad? But if I'm also then looking for, how do you answer? So if you tell me your pain is 20 out of 10, I go to okay, so we have a degree of catastrophizing here and we have a degree of not coping.
Yeah, I was just going to say lack of coping.
Yeah, so I'm then going to go, okay, part of my strategy needs to be, I need to manage the catastrophizing, I need to manage the coping strategies, I need to make sure they're either already tied in with a psychologist or I need to link them in with my psychologist. And so that's what that sort of stuff means to me. If you're saying, my pain's 3 out of 10 at its worst, all right. Well,
there's not much sensitization, not much amplifiers, not much other mood components to pull apart. Yeah.
I'm also now going, well, any of my procedural stuff's comes with risk. Does the risk benefit ratio here play out? And like when you got 3s, well, the answer's probably no. And then the other thing is that, how often are you pain free and things along those lines, because they then start to define how I'm going to manage somebody. So even though I'm asking a number, it's
not about the number.
It's not about
what the number represents, and then how you address those other pieces. And anyone who lives with pain can attest to this, is that it's when the suffering piles on that you start to have to listen to the flare episode, basically, right? When then lack of coping, capacity changes, and it's not that the driver changed; it's the surrounding context pieces with all those.
And I think that what's really interesting, particularly with something like the other thing I really listen for with that is if someone says, "Oh, what's your pain out of 10 at its worst?" Well, it's a 9. What's it out of 10 on average? 8.
Yeah.
However, how often are you pain free? Never. Okay. In that setting, my ability to get somebody better drops off,
right?
Because there's
nowhere to go.
It is it's always
it's always this, always
horrendous. It's always this, always.
Yes.
And so it becomes.
I've been that annoying patient too.
And so you then need to be able to take some different strategies about how you're going to get there.
Yeah.
And if someone just says, my pain's 10 out of 10 all the time, okay, well, there's 2 things that happens there. Number one, it's hard to get that patient better, but it's also really hard to do a diagnostic block on that patient.
So even begin to better diagnose or narrow stuff down, then you're it's a catch-22. You're sort of handcuffed.
Oh, but I also think that patient really struggles with the pain scale.
Yes.
They've
lost calibration of the pain scale. And that does happen where you get in too long and too high of a number, and you kind of it's all the same.
Mm-hmm. Yeah. And so that gets really hard if you want to do a diagnostic block and their pain's always 10 out of 10. Does it ever? It doesn't shift.
It's setting yourself up to not have a good outcome.
It's setting yourself up as when you do the block to have a negative block. So guaranteed. So it's interesting. Interestingly, I had a patient the other day, and I only think about it because it's a very rare event, in that they were the opposite, so that they undercalled their level of pain relative to their disability because of they recently had a 10, real
gives a 10. Good juxtaposition, a real comparison.
They were like, okay, so that was a 10. This thing is a 3, or this thing is a 5, but I have to lay down every half an hour, and I can't go to work, and I can't do any exercise, and I can't do anything around the house. And I'm like, okay, full respect to you, awesome.
It's not a 3,
but that's not a 5.
Right.
And so, but the conversation there is because I was able to have that conversation with her. What it is, because I actually am going to do a diagnostic block on her, is that the conversation after the diagnostic block will not be about did your pain decrease. It'll be what else were you able to do?
Right. The function, the surrounding.
Did you improve functionally?
Yeah.
And
could
that
you do
will
more?
be
right.
Yeah.
Yeah.
Did this take away the pain that stops you doing the things you want to do? And that will be the conversation I have with her, rather than using a number to guide me, which is interesting in itself. That's sort of, but it's a rare event. Doesn't normally happen that way.
Do you find, because I start with a lot of people when they're kind of in the worst position that they've ever been in, frankly, and they don't come to me though if they're not open-minded enough to take in and absorb what I'm saying about the things that make pain so much worse and intolerable, and like that it's a 10 out of 10 all the time, there's nothing I can do. Do you find that there is a sliver of that type of patient who you can sort of get through and reframe things in a way that they're open to starting to tackle and look at it differently? Or is it just, this is a no-go? Because I think by the time people reach out to me, they have made that shift a little, but I wonder.
Depends on the type of patient. Okay. So the answer to that question is
because those patients can be helped, but who of those of that subsection can be helped?
My answer to that question is the patient with hypermobility, yes, that has got everything, like has got all the collection, and we really need to do a HEDS.
We've really been doing it in the background for a year.
But for my HEDS patients, the answer is yes, because what I can do there is I can provide them with a structure,
show them the lay of
in
the land,
how this all fits together. Why do they have these million different conditions?
Right.
And how are we then going to go through the process of treating it? And they're like, yeah, okay, great.
They're relieved. Yeah, that's probably the same thing in my population. So that, yes, you are then, thank God, let's go, rather than.
Yeah. For patients that I struggle with within that setting, I think that there's patients that have probably got that sit in the realms of personality disorders.
Yeah,
and
psych components that are.
I struggle with it. If they're 10 out of 10 and we've got a personality disorder and you cannot get any link between other things amplify that pain.
Right. Or they're like, no, it's not that. It's not my psych stuff. It's not.
Yeah. If you're in the setting where, that's a really interesting point.
Right.
Because I think that most people in that setting, most people in that setting that have multiple amplifiers get to this point where they recognize that
it's
at least their emotion,
there's some
and their
part
stress and the depression does amplify a bit of it.
It can't be helping. Right.
For the patients that are like, nah, my emotional status has nothing to do with my pain.
I think that's the cutoff. That's the answer to our question.
Yeah, I think that's really difficult. If you can't,
do you have denial or do you have open-mindedness?
Yeah. And it's just a maybe. Like maybe it's playing a role, because as soon as you're like, well, emotional status amplifies pain, then you can take people into, well, metabolic status can amplify pain.
Right. So these things, it's not just, we're not picking on your, mood. Right.
Yeah. And your diet and your blah, blah, blah. So, but I think if you can't get across that first step of, my emotional status has nothing to do with my pain. They're pretty hard to pass.
And there's the hard reality too of sometimes it is just easier to not get better. And that's really tough to see too. Usually people don't work with me who are like that, but I've had some outliers where I see that that's the actual challenge at hand. And then you can't want it more for someone else. You can't, do it more than them. So it is unfortunately at the end of the day on the patient to take the initiative and then reach out for help and have someone design and create a plan and support and then support them in that, no matter how difficult. But it has to be, I am willing to do kind of whatever it takes to get better. And I want to do that. So.
And I think, look, the point of today was really to be able to give you some tools so you can define for yourself, what are those things? Right. Have I just got body part pain? Have I just got neuropathic pain? How sensitized am I? Blah. What components of my sensitization?
What's my functional baseline?
Yeah, where I'm at a functional perspective, where am I emotionally? Great. This is where I'm at. That's my baseline. Let's go fix some of it.
Yep. I'm inspired.
Right, let's go.
Okay. All right, guys. That's all we got for you today. Make sure you check out the website where you can get access to all of the different tools that we talked about today, as well as the tool that Dan and I have put together that'll be in quiz format for you guys to be able to go through, fill out, and then begin the process as we release more and more episodes of working your way through this and reference the ones that we've done thus far as well from an algorithm perspective to kind of remind you how things present, right? How can you draw your pain? What do things feel like? And off you go. All right. Thanks, guys. We will see you next time. Take care.
Thanks, bye. Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.